Hey everyone, welcome to The Explainer. Today, we're looking at one of the most fascinating and honestly one of the most persistent challenges in modern healthcare training. Think about a modern hospital for a second. It is an absolute powerhouse of data. Every single beep of a monitor, every pill dispensed, every lab drawn, it's all meticulously logged in the electronic health record. We literally have more data at our fingertips than ever before. And yet, despite this absolute ocean of information, we face a massive blind spot when it comes to the very people providing a huge chunk of that care, the medical residents. How do we actually know if an individual resident physician is making high-quality clinical decisions? It sounds like it should be a simple question, but as we're about to see, it is incredibly complex.
Okay, let's dive into this, because the irony here is actually quite striking. We have these data-rich electronic health records that can tell you exactly what time a patient's potassium level was checked, right? But we genuinely struggle to pinpoint which specific doctor's brain was responsible for the decision to check it. Residents are a core part of the hospital engine, but they work in these highly integrated teams. So when a patient gets better, or when a protocol is followed perfectly, who actually gets the credit? And more importantly for medical education, how do we give these doctors in training objective, data-driven feedback on their individual performance?
Here is our roadmap for today's explainer. Number 1, the feedback gap. Number 2, testing resident-sensitive measures. 3, the attribution challenge. 4, statistical reliability concerns. And finally, number 5, shifting to program-level monitoring.
Section 1, the feedback gap, the observation problem.
To understand why this matters, we have to look at how competency-based medical education works right now. Currently, evaluating a resident relies incredibly heavily on direct observation. An attending physician basically watches a resident perform a task or present a case and then subjectively grades them. But observation is limited. Attendings obviously can't watch their residents 24 hours a day. Because objective, resident-level data is missing, trainees rarely get concrete feedback on the actual quality of care they provide daily. Well, to solve this exact problem, an absolutely fascinating study was published in the May 8, 2026 edition of JAMA Network Open by Dr. Brendan Tang and a really extensive team of researchers. They asked a bold question. Can we mine the electronic health record, the EHR, to automatically generate objective performance reports for individual residents? They wanted to bridge that feedback gap by turning the hospital's digital paper trail into a real-time report card.
And they did not mess around with a small sample size. This study utilized the Gemini MedEd database, tracking an astounding 132,291 patient admissions. This data spanned across 5 different Canadian teaching hospitals over a 10-year period, linking patient admissions during overnight call shifts to nearly 800 senior internal medicine residents. This scale? It's literally unprecedented for medical education research. It gave the researchers a massive canvas to see if they could actually isolate the performance of individual trainees.
To do this, they use something called an RSQM, or a resident-sensitive quality measure. What exactly is that? Well, instead of looking at downstream outcomes, like whether a patient survived, which, is influenced by a million different factors totally beyond one resident's control, an RSQM looks at clinical processes directly influenced by the resident's immediate decisions. Did they order the right antibiotic? Did they order a totally unnecessary blood transfusion? These are the direct footprints a resident leaves in the medical record.
Section 2, testing resident-sensitive measures, the care variation framework.
The research team didn't just pull these metrics out of thin air. They developed 7 specific RSQMs based on clinical practice guidelines, focusing on general internal medicine, specifically pneumonia, since it's so incredibly common. But to really understand if residents were performing well, they needed a framework to evaluate the variation in the data they were seeing. They used what they called the care variation framework, which is beautifully simple. It categorizes care into 3 distinct buckets. First, low-value care. These are things you generally just shouldn't do, like inappropriate red blood cell transfusions. You expect to see this happen very rarely with narrow variation across the board. Second is discretionary care, like ordering advanced imaging. This depends heavily on the specific patient context, so you're going to see wide variation between different doctors. And third is evidence-based care, like giving the correct first-line antibiotic for pneumonia. You expect this to be highly frequent with very narrow variation because, well, everyone should be following the same guidelines. This framework set the perfect stage to start grading the residents.
Section 3, the attribution challenge, the mystery of the missing data. Now this is where the study takes a brilliant, totally unexpected turn. The researchers took their magnifying glass to the data, expecting to easily grade individual residents. But as they zoomed in, the image didn't get clearer. It got incredibly messy. when they looked at the evidence-based measure, ordering the right pneumonia antibiotics, they hit a massive roadblock. What's really interesting here is how the data completely changes its story depending entirely on how you define time. When researchers only looked at antibiotic orders placed after the patient was formally admitted by the resident, it looked like residents were only ordering the right drug 22.5% of the time, which, actually, that's terrifyingly low. But wait, when they expanded the time window backwards to include the emergency department, the rate jumped to 52.6%. And when they looked forward into the morning of the next day, it rocketed up to almost 76%. The residents' apparent skill was wildly swinging based purely on when the researchers started and stopped the clock.
So here's the crucial point. A hospital does not operate like a solo practice. Individual attribution fails completely because clinical decisions are fundamentally interdependent. That 22.5% rate wasn't because the residents were bad doctors. It was because the emergency department physicians had already ordered the antibiotics before the resident even met the patient. I mean, why would a resident order a drug that's already been given? Plus, you've got attending physicians changing plans during morning rounds, and you have junior residents physically typing in the computer orders under the verbal direction of the senior resident. The electronic health record only captures the keystrokes. It doesn't capture the actual conversation happening in the hallway.
Section 4. Statistical reliability concerns. The microscope is blurry. So the attribution problem was just the first hurdle. The second hurdle the researchers ran into was purely mathematical. When you try to evaluate an individual resident over the course of their training, you run into severe issues with sample sizes. 18. Just 18. That is a fascinating number. Over the entire 10-year study period, across all those overnight shifts, an individual senior resident only managed a median of 18 pneumonia cases. Think about that for a second. Pneumonia is one of the most common reasons for hospital admission, and yet a single resident only sees about 18 of these specific cases while actually running the overnight team. When you try to do performance math on just 18 cases, the statistics simply break down. Add to this the fact that some discretionary events, like ordering a chest T-scan for pneumonia, happen in fewer than 5% of cases. You are dealing with tiny sample sizes and incredibly infrequent events. If resident A orders 1 CT scan and resident B orders 0, resident A mathematically looks vastly different. But in reality, it's just statistical noise. It is measurement error, not a true reflection of their underlying clinical competence.
Section 5. Shifting to program-level monitoring. The wide-angle lens.
The researchers realized that treating the EHR like a microscope to grade individual residents was fundamentally flawed. It was way too blurry. But let's move to and see how this built. When they zoomed out and treated the data like a wide-angle lens to look at the entire residency program, suddenly the picture became crystal clear and incredibly powerful. Look at this direct contrast. Individual monitoring is plagued by misattribution, literally giving credit or blame to the wrong person. It suffers from small sample sizes and massive measurement error. It's essentially unusable for high-stakes grading. But program-level monitoring, that is highly statistically reliable. By aggregating the data of all residents, all that noise cancels out, and you capture true system-level trends that provide actionable insights for the hospital and the educational institution.
For residency program directors out there or hospital administrators, this is the gold mine. This is exactly how you use this data today to actually improve your training programs. You stop worrying about grading Dr. Smith or Dr. Jones on their 2 a.m. overnight shift. Instead, you track an entire cohort's progress over the years. You use metrics like second-line antibiotic orders as a radar signal for your program's overall antibiotic stewardship. If you oversee multiple hospitals, you can use this data to pinpoint cultural or workflow differences between training sites. Ultimately, aggregating this data drives continuous quality improvement, allowing you to tweak the curriculum exactly where the data shows the system is weak.
And this brilliantly illustrates the power of that wide-angle lens. The researchers noticed a massive, unexpected cluster of first-line pneumonia antibiotic orders happening between 8 a.m. and 10 a.m. Now, the overnight resident finishes their shift at 8 a.m., so why the sudden spike in orders right after they leave? Well, it's because that is precisely when the morning attending physician arrives, reviews the overnight cases, and adjusts the treatment plans. The program-level data literally mapped out the hidden rhythm and team dynamics of the hospital's workflow. It showed exactly how supervision changes patient care in real time.
Which brings us to our final thought. This study set out to create a report card for individual residents, but the data pushed back. It revealed that in modern medicine, care is so interconnected, so heavily reliant on teams, protocols, and workflows, that trying to isolate one doctor's footprint is basically impossible.
So as we push forward with electronic health records and big data in medical education, we have to step back and ask ourselves, are we really trying to grade the resident? Or are we in fact grading the system they are learning in? Because fixing the system will almost certainly train better doctors. Thank you so much for joining me on this explainer. I really hope this changes how you view medical data, and I'll catch you on the next one.